die in childbirth. Now, for a country that's a middle-income country, you will agree with me that's abominable. If you just look at institutional deaths occurring in our public health hospitals, it's much lower at about 160 per 100,000 deliveries. But still, you must argue, and I must agree with you, that this is unacceptably high. So to answer the question then, does South Africa need community health workers and mobile health? I guess the answer is a no-brainer. It's a yes. We have done a few audits of how many community health workers we have in South Africa, and our best guess is that we have upwards of 65,000 community-based workers of various types in South Africa. What's the problem? Like many things in South Africa, we have let 1,000 flowers bloom. We are very good at pilots, at small-scale projects, and letting 1,000 flowers bloom. What we are not terribly good at is figuring out what to do with 1,000 flowers once they have bloomed. And by that I mean scale. So in my mind, certainly in South Africa, and I would imagine that this is true of many developing and middle-income countries, that two things are needed. One is focus, and the second is scale. And I think this conference does help us to focus on one aspect of what needs to be done, and that is the use of technology to improve health outcomes. So what's true of South Africa, and I guess is true of many of countries to the north of us, is that we have many small-scale projects. Now, projects and innovations and pilots are not bad. Let me be clear. However, once we know what works, we need to go rapidly to scale. And my own understanding of both the literature and my own country is that that's what we are really struggling to do. So given this significant burden of disease in South Africa and the fact that we seem unable to reach the MDGs, what is the plan? The plan for primary health care is threefold, led by my minister. One is to put a primary health care outreach team in every electoral ward in the country, and we have about 4,000 of them, led by a nurse with about 4 or 5 community health workers, depending on the population size of that particular ward. And this team will do a range of things, including mobilizing health in communities, doing minor curatives, doing screening, etc. However, what we don't have for that to work is an information system that will, in either real time or any time, provide information on the status of that population. The second stream of our primary healthcare re-engineering will be on school health services. And this will range from early childhood development through to children in secondary schools. And the third stream, because of the concern of the minister and ourselves on high levels of maternal and child mortality, is to put over time, of course, put a number of specialists, including pediatricians and obstetricians and advanced midwives, within reach of each health district in the country. As you can see from this, that the base of the pyramid of primary health care is going to be community health workers. So what's the experience in South Africa and elsewhere on the use of mHealth technology with respect to children, mothers, and because HIV is such a pervasive cause of mortality and morbidity in our countries, I focus also a little bit on HIV. A clinic in Johannesburg uses text messaging to remind HIV patients, including pregnant mothers, about clinic appointments and to pick up medication. By using mHealth in this way, missed appointments have fallen between 2007 and 2011 from 15% to 4%. We are now trying to do something similar in various parts of the country with TB patients. As you know, you may know our TB defaulter rate was stuck at 10% for many years. It's now down to 6%. The consequence of having high levels of defaulting on TB, as you know, has resulted in multiple drug-resistant and, in some cases, extreme drug-resistant TB, which affects mothers as well as children. As you know, we don't have very good technology to detect TB in children, so it's very important to prevent TB in children. South Africa's Medical Research Council and partners have used cell phones to collect data in a recently completed survey on the prevention of our prevention to mother-child and to child transmission program in the country. I might add parenthetically, and we will present this data at the AIDS conference in Durban that starts tomorrow, that the transmission rate of vertical transmission rate has dropped from 8% in 2008 to 4% in 2010 in South Africa. And it's largely due to a number of factors, including the work that community health workers have been doing. If survey data can be collected and available in real time at a central database for a survey such as the PMT-CT survey, this application can be used to provide real-time data by community health workers on their household visits. And this has already been shown in a small project in KwaZulu-Natal called the Good Start 3 project. So as you can see, we know what works already. I'm not sure that we need many more projects and pilots. Some other examples, as you know, the Millennium Village Project has a number of village projects, especially in Eastern Africa. And in Sauri in Kenya, they were able to, using community health workers, focusing just specifically on malnutrition, malaria, and diarrheas, they were able to decrease the under 5 mortality from 148 per 1,000 live births to 81 per 1,000 live births. So in 3 years, they were able, using very simple technology, to reduce under 5 mortality. And the use of mHealth was really to send text messages, to register patients, and to obtain support when they were dealing with a patient who needed additional support and care. Child Count Plus, again in the Millennium Village projects, have used community health workers, again, to register patients, to report on their health status, and also in real time to view the health of communities. And they were able to reduce the treatment gaps using text alerts. So colleagues, I think we know a lot about what works. Another example from South Africa in Gauteng, community health workers use cell phones to support the PMT-CT program to remind mothers of follow-up visits to clinics. Now let me tell you why this is important. In the survey that was done by our Medical Research Council, they basically sampled all our facilities at which immunization is provided at 6 weeks post-delivery. They were able to find 60% of the kids who were eligible for vaccination at 6 weeks. So we have lost 40% of the kids. Now, very clearly, using community health workers and mCell technology, we can find those kids and ensure that they are immunized, which means that if they are part of the PMT-CT program, they will also get assessed for transmission at 6 weeks, which is what we want. Here's my lamentation again. All of the projects, many of them, or most of them, are small-scale projects and pilots. The big question is, why are we not able to go to scale? And I think that's the question that we should grapple with for the rest of this day, at least. And I guess that begs the question, what is needed to go to scale? Now, here's a quote from Barriers and Gaps Affecting mHealth, which is in the mHealth Alliance website. And I truly believe this, and I'll tell you why I truly believe this from my own experience. They say, and I quote, "The current single solution focus of mHealth needs to be replaced by using mHealth as an extension and integrator of underlying health information systems along the continuum of care. Creating a strong collaborative foundation will be instrumental in driving and positioning public and private investment in mHealth in a way that contributes to achieving improved access to health information and services, health outcomes, and efficiencies." Now, let me give you 2 examples. In April last year, our president launched probably the largest HIV counseling and testing campaign in the world. By June this year, we are supposed to have tested 15 million South Africans for HIV. The good news is that we are just over the 11 million mark at the end of April. Now, to collect the information, because the minister wanted the information weekly, we thought we will use an mHealth application supported by DFID in this instance. As it happens, it's taken us a long time to use existing technology to come up with this strategy. Why is that so? Because the National Department did not have an mHealth strategy. So one of the barriers to scale up is having a national strategy. And it's clear to me that unless you have a national strategy, you will have resistance to scaling up a project based on a single intervention. What was the reason for that? The question is sustainability. What will happen to that technology and that investment after the campaign has ended? And that's a concern, I think, of most people who are investing in any project, in any technology. Another example, we've just started, and this is about a month old now, we've started an mHealth project around our TB outreach program. In February this year, in order to decrease defaulter rates, we instituted a new program focusing on 9 of the districts in the country with the highest TB caseloads. The idea was for a nurse and community health workers to go into households of index patients to screen all members of that household. And we wanted then to use mHealth to record the data coming out of that. Now, we've got data for about a month on that, and it seems to me that that application can work. However, one of the key findings of that application is that in every household, on average, we only found 2 people. Now, there is no way in South Africa you would have a household with 2 people on average. Clearly, we're missing out people who are not in homes during the day. So the question is how to get at congregate settings outside the household. But that was kind of a by the way.